People. So formally to welcome you all to this morning's meeting. My apologies for the voice. It's one of the dog ends of having a mild dose of COVID. It may disappear altogether, which could be a benefit. And Dudley, you're welcome, sir.
Well, thank you very much, and then thank you for everyone for joining us. We roll on, and it's April, spring is upon us, and some of us may have been blessed with some summer weather across the board, other with rain, and we're still trying to look for the sort of the green shoots coming out. I'm sure lots of you have been paying attention to the many changes outside of the sector. Probably those will realize that not many people are wearing masks or doing tests, so forth. However, we know that it's still covering and looking after potentially those who are more vulnerable, but also ourselves as well in our workforce, and the resilience is still strong. And so we hope that everyone is still able to keep themselves upbeat somewhat. But one of the most important things is meetings like this is that we're able to update you, share, and also with things changing in the sector, we try our best to keep you informed what's going forward. We run a range of topics across the year, and some, if you have any suggestions, please inform us. We also, and Peter does this wonderfully, do meet with bodies across the country and try and share and update. We also speak to commissioners and try to be a voice as well for all those who come to this meeting. We have a vibrant WhatsApp groups, or WhatsApp groups, should I say, and that we manage so we can still send messages outside of this virtual meeting today and keep up to date. And we'll be sharing some bits and pieces of information of things that we will also are doing, and I will show you some of the things I'm doing as well for us to join and to keep us upbeat as well. So apart from that, I welcome everyone to the meeting, and Peter, I believe you can start if there's anything else you want me to add, and I can do.
Okay, many thanks, Dudley. We will put a few things in the chat as we go along. I'm sure you're aware that April is a stress month. So there's a few things around that. We've also got a couple of surveys, Vivaldi being one, that we'd like to try and involve some care home providers in if we can. I won't say very much about Vivaldi. I'll do a little bit about it later on, and then if people are willing to be part of that, if they contact me, I can go through detail and put them in touch with UCL who are hosting it. Right, there's loads of people streaming in. The main purpose of today is to talk about CQC inspection, and we're fortunate to have Julia Spencer-Ellis from CQC with us, and I will hand over to her, and she will be co-host, and we'll put the slides on. And by the way, all the slides, etc., we will get and we will put on the website later on. Julia, welcome.
Thank you. I am Julia Spencer-Ellis. I am an inspection manager in adult social care working across South East London. Now, the slides I'm going to use today, I am going to say that at the moment, they haven't been properly signed off by CQC's engagement team, so I cannot share them with you for publication. I had to ask very nicely to be able to access them. So as soon as they have been approved, I will email them over so you can share them. But right now, we have, as you can, I'm sure you appreciate, quite an extensive sign-off process for slides for publication. So these are the official slides, but they haven't been fully signed off for sharing yet. So you will get them, just not straight away. So the ask from Peter today was that I did a presentation about our inspections using remote technology. So those are the inspections where we're not doing a site visit. So I'm going to be talking about that, and I'm just going to try and share my screen so that I can share my presentation with you. Let's hope that works, because I am not normally a Zoom person. I am going to have to rely on you telling me if I've got this correct. So you should be able to see the slide one of using remote technology to complete inspections. Could somebody who's got their camera on nod at me if that is visible? I think I've got some nods.
You're fine, Julia.
Brilliant.
You just, if you want to enlarge the screen.
Yeah, I'm gonna move into presentation mode, hopefully. So now can you see?
Yeah, but we can also
you can see the presentation, so I need to flip that round.
The one of them, yeah.
Okay, just give me, I'm going to unshare and I'm going to share the other screen so that that will work. So give me 1 second. So I'm going to share.
The joys of virtual presenting.
I'm much more confident in Teams because I use it more often. There we go. So now you should see that slide.
Fantastic.
Perfect. I feel accomplished at Zoom. I was not a Zoomer. I spent too much time on Teams, and when my friends all suggested having it a Zoom in early pandemic, I was like, no, that's just what we do at work. Let's not do that again. Okay, so what I would like to say, we're talking about inspections using remote technology. So my outline for today is that I'm going to support you to understand when and how we will use inspections using remote technology for ASC locations, help you understand what is in and out of scope and how we do the virtual inspections and the report, how we make sure that we've gained and reviewed the evidence appropriately, reassuring about how we share and store the evidence, what inspection teams look like, and then I've got a little bit about our future strategy and methodology because I'm aware that it kind of links in and that will be an area of interest. And then hopefully we'll have a bit of time for you to be able to ask me any questions, quiz the inspection manager while you've got her in the room. So the original question came up, and this was actually a question we were asking ourselves pre-pandemic, was are there circumstances in which we could inspect care at home which would enable us to gather the evidence we need to make a robust person-centred judgment based on people's experience without visiting the agency's office. You know, particularly in London, we've got a lot of dom care providers in offices, and there were situations where we felt like actually that day spent in an office wasn't actually adding value to the process. We had really digitally enabled providers who were able to email us everything, and essentially we sat in an office, both of us working on a laptop at the same time. And we want to make sure that everything we do at CQC is adding value to the experience. So having posed that question, we then dug into the issue, and that was that, you know, we explored the fact that the agency offices can be time and resource intensive. So you've got we understand and recognise that the process of inspection and a site visit can be quite disruptive, and it's our time as well. Being in an office can sometimes lead to a focus on policies and procedures rather than the experiences of people. And then when we kind of moved into the COVID time, those increased risks of cross-infection, both COVID-19 and winter flu, recognising that, you know, a lot of care at home providers in London are in, you know, one desk office spaces, and therefore particularly during the pandemic it was quite an enclosed space to be introducing us into. That was risks both for our inspectors and for our providers. So we thought, as the pandemic was allowing us to have lots of more kind of online tools with the potential to replace the need for physical visits, we would explore that. We needed to explore and identify the circumstances where a remote inspection could help us and where it would be appropriate. We conducted a formal pilot of this methodology, engaging with people, using services, with providers and with inspection staff to identify the potential benefits around travel, ability to focus on the most important things, and more flexibility for providers and inspectors. The pilot ran in autumn 2020, so we didn't rush to this straight away at the pandemic. We took our time to plan it properly and we did the consultation, and the inspections took place between September and November. And we chose a really wide range of services. So we had services that were good and outstanding and were considered, oh, hello, I've pressed the wrong button there. Were good and outstanding across all areas, but we also covered a range of size So we had little agencies that were only working with kind of 5 people, and then we had some really big kind of corporate providers working across a big patch. We also considered rural and urban environments, and we gained consent from the providers before we included them in the pilot. So that was how we ran that. And we did 48 inspections as part of this pilot. Oh, sorry, this slide needs updating. Those have all now been published. And we had the agreement from both inspectors, inspection managers and providers that the evidence was robust and it was an accurate picture of the service. The feedback from providers was positive, and that they agreed that we ended up with actually better engagement with staff and people who use the service, because we were able to do more contacting and speaking with people and staff. The consensus was that this was a useful tool, but it was not something that would fully replace on-site inspections in all circumstances. And there was a sense that the inspection is very similar to a site visit inspection, but there was a great dependence on how digitally ready services were. So we agreed, after having done this pilot, that it would be rolled out as a possible methodology that inspectors can choose to use, and it was included in our public consultation in January. So just to be clear about which services will and won't be in scope for these inspections, because it isn't suitable for all inspections. Services where we need to observe care are not suitable for remote inspection, because we can't observe care remotely. That doesn't work. So within scope, we've got most domiciliary care agencies and extra care housing schemes, but out of scope are potentially supported living and shared life settings, particularly because those tend to support people with more complex needs who would be less able to engage with us using remote technology. So we need to be in the room to talk to those people and to observe the care they're receiving. We are not limited by size or rating in terms of the services, but if we've got a service that provides multiple service types, so we'll have locations that have got both a care at home agency and an extra care service run from the same office, that's probably a bit too complicated to not go to site, because we need to be clear on the separation of services when we're writing our reports. It's completely appropriate for us to do the follow-up and undertake enforcement if we're undertaking a remote inspection, but we probably wouldn't do a remote inspection for services that are primarily supporting people with learning disabilities, that are not supported living or shared lives. So we have got some highly specialist care at home services that support people with learning disabilities in the community in their own home, that are not supported living and shared lives. And again, the communication needs of people mean that we probably wouldn't do that remotely. I think we also probably wouldn't get the best out of the inspection. So there are things that will make, we're not saying that all care at home will be a remote inspection. It's a tool in the box. So there are things that make us more likely to consider it, and then there are things that make us less likely to consider it. So, oh, sorry, that was an accidental click. And that is a meeting that's about to start. So we've got some positive indicators. So where people using services are able to engage with us by phone, video, or other means such as email, that means we're more likely to consider it. I think if we've got a service user group that we know aren't going to be able to engage with us remotely and their families might struggle, then we're less likely to consider it. But if we've got the people who use your service are able to engage well over the phone, can use digital technology, they've got relatives and friends and family who are on the emails, then that means we'll consider it. If you're a service that holds most or all of your records electronically, that tends towards us being able to consider that. It's you're set up for us to be able to access things. And we would, if you're a manager who's comfortable with the IT, you're someone who's quite happy to extract an email and understand zipping and unzipping folders and using secure servers, that would be a positive indicator that it might be suitable for your service. Where we're less likely to use it is things where if people are unable to engage with us virtually, and where we would normally have considered asking to do some home visits as part of our inspection. If your records are all paper-based, it's not going to be conducive to you to ask you to scan and upload all your records, to turn them into digital records, to email us. That's not a fair burden, so we would come and look at those paper records. If the managers aren't comfortable with the with the IT systems and are less able to kind of convert and share evidence digitally, it wouldn't be appropriate for us to use that methodology. If we've got any concerns about the standard and quality of record keeping, we're probably going to want to see those records live in real time rather than have them sent to us digitally. And any services where we've got a concern about closed cultures or management and leadership, we will do a site visit. Or anything where we needed to be unannounced, we would not do a very short turnaround. We wouldn't use this methodology. The nature of remote inspections, they are announced because we need time to pull together the records to review. So the next topic is about the legal context. So can we rate? Yes, absolutely. Inspections using remote technology are inspections, so we can rate, we can improve, change, or keep the same on the rating. Can we enforce? Yes, absolutely we can. That we're using the difference is that we're using a slightly different part of the Health and Social Care Act. So as an inspection where we physically visit the office is completed under section 60 to 62 of the Act. But when we do a remote inspection, it's under section 46. And the rating and report will be issued under the provisions of section 46. And there's a slight change to the wording on the report to reflect this. So this is a slide about kind of the process that we go through before we would decide and inspect. So we would really do some very detailed planning. I mean, all our inspections are subject to detailed planning. We have lots of tools to support inspectors to do that. And if as part of that early planning, they identify that actually you're quite a digitally enabled provider, you're set up in a way that would facilitate a remote inspection, that will be included. We would obviously still get our stakeholder feedback. We would establish really clearly what's the evidence that we're going to want to review, so that we're making really clear requests to you as managers about what are the records we want to see. So that it's really clear that we're putting in what information you'll need to send to us so that we can evaluate it. We'll set up contact with the registered manager. So we'll do that. The reason I can now access Zoom and I couldn't 12 months ago is because we've recognized that we need to use the programs that work for providers. So setting up Teams or Zoom channels so that we can regularly catch up with each other and have regular meetings with providers just to kind of keep in touch as we go. We would still expect to see an expert by experience involved in the inspection team, and potentially a medicines team inspector to support us with those elements. And the same timescales as we would expect for an inspection in person, in terms of how, I'm not sure what 5 working days means there, but that's about how long we would take to do the inspection and provide feedback. It is very, very likely that we would give you at least 48 hours notice of these inspections, and that notice would come with an explainer that it would be a remote inspection and kind of an idea of what that will mean. So when we're gathering the evidence, we'll make sure that we've got a key list of documents that we normally review during an inspection, and we'll ask you to send those over to us. We'll use our visiting video conferencing and screen sharing, so you can show us things on the screen. We've got password protected zip emails, we've got a secure portal, and that way, that thing where we can just ask you to show us where in the file things are. The same way that if we're on a site visit and we're looking through a folder and we say, okay, I can see that part, where can I find the next bit? We would do all of that the same way. I'm not sat next to you, I'm on the team screen with you. In terms of Teams, Teams is CQC's preferred method, but obviously if you don't have Teams or you really don't get on with it, we do have alternatives, but our IT people definitely do prefer Teams. And we've been using Teams and soft phones for kind of nearly 2 years now, and we're, you know, most of the providers we work with are now very familiar with that as our approach. Inspectors are still making notes as normal, kind of using our kind of agreed note-taking processes. All the evidence that you email over to us, so previously we might have taken copies of things or still asked you to email us over. This is now all emailed over. We follow our existing processes, so we've got our customer relationships software, which is where we store all our information on inspections, and that will all go in there the same way our business as usual inspections, everything gets added to that. And once they're on there, they become our records and they are subject to our retention policies, which means we've got, you know, the same way you guys do, we've got policies and procedures on how long and how we retain records. So when we're doing our inspections by remote technology, our approach to corroboration is identical to that on a physical inspection. If we need more information to make our judgments, we will ask. If we thought that you were a digitally enabled provider and we were going to be able to do it remotely, but we get kind of 2 days in and we become aware that actually this is far more burdensome on you than we thought it was, and actually it's not working, it's going to be much better if we pop on our coats and come round to the office because it's not working, then we will do that. We can pick up and change. What's been quite useful during the pandemic is actually changing it the other way, where we've had a number of inspections where we'd planned to be on site and then there's been an outbreak of COVID in the office, and we've been able to establish that actually they are very digitally enabled, and we've been able to get that stuff everything sent to us, so we've not lost momentum on doing the inspections that people have been wanting to have done. Where we do the planning and the asking for information, it really does help avoid the duplication of records, so we'll only see what we need to see and we don't see the same records twice. And the same way as for our normal inspections, at the moment we complete our feedback form and share it with the registered person, so that we can go through it together after we finish the evidence gathering. So when we've completed the kind of evidence gathering stage of the inspection, our process for rating and reporting has not changed. So it goes through peer review, it goes through manager review, judgments and are considered. There is a slight variation on the text, which I referred to earlier, because we're using a different piece of the law. So where normally in the background to the inspection, it will say we carried out this inspection under section 60. It says we carried out this performance review under section 46. And it just gives a little bit of clarity on that point. We have the normal procedures around factual accuracy and ratings review apply, so that's absolutely fine. And we would, if we get a significant factual accuracy challenge where the reliability and validity of the evidence is challenged, we may consider a re-inspection, but that's not guaranteed. Like, that would be a very unusual outcome, but if that process did show that we hadn't kind of followed our process, and the same applies for ratings review, so it would be our normal process. Okay, so that is what I was going to talk about, the remote technology. I'm now going to move on to talking about how this links to our new strategy. I'm going to pause and take a sip of water, and if anyone has questions about inspections using remote technology, I think this might be a good spot to pop them in, if anybody does.
People can either raise their hand and we'll try and pick up, or they can put something in the chat. There was one question, Julia. I know you're drinking water, so maybe once you sort of wet your throat. Not everyone may be great with digital technology and planning, or other people still are on their transformation journey, digital transformation journey. So I guess some of the providers will say, where does that leave them? Because they feel almost, if
they would get a site visit. They would get a site visit. So really clearly, if yes, CQC definitely is expecting providers to become more digitally enabled. You know, you cannot register with us now without being able to use our website and using our platform, but we also know we've got existing providers. And that means that, you know, if you're an existing provider and you're not digitally enabled, you will get a site visit. I think increasingly it is going to be very difficult for providers who are not digitally enabled to meet the characteristics of a good service, because so much of health and social care is online. You know, if you're not able to be online, how are you able to ensure people's healthcare needs are met if you can't do that? So I would strongly encourage you to explore how you can become more digitally confident if you are not. But in terms of this, if you're not digitally enabled or you're not digitally confident, then we would do a site visit inspection.
Okay, there's a question in the chat which is quite an interesting one, and I know you've got to go lead on to your next part. But one of the questions was, does this apply across the board? That will be not just dom care, care homes, learning this, to various different settings, but specifically it was dom care was one of the questions from the chat.
So as I said on the earlier slides, this is an approach that we're using for care at home services. It wouldn't be appropriate for care homes because we have to observe care in care homes, and likewise that's why we've said we wouldn't normally use it for supported living. And we absolutely are unlikely to use it for learning disability services, because so much of our approach in terms of right support, right care, right culture is reliant on observations of care. So for those services and those service types, it is unlikely that we would do a remote technology inspection, because we need to, anything where we need to observe the care, we would not be doing an inspection using remote technology.
Okay, and final question before I get to go, unless anyone has a pressing question. It's been mentioned, can your ratings be changed through this form of inspection?
Yes, they are ratings inspections. So I feel like I'm about to do a credit card disclaimer. Your ratings can go up as well as down. But yes, these are ratings inspections. So you would get a new rating on the key questions that we looked at.
Okay. And I'd see there's a hand raised from Diligent Care Services.
Yes, I've just posted a question there.
I am not confident enough on my Zoom to both display slides and look at chat. I think
Okay, I'll make it simple. Unless Diligent Services want to say, I don't mind saying it. It's up to you. You can ask your question.
Okay, the question is, when you're remote inspecting, would you be asking providers to have a shared folder that you can access, or will it be on the day?
So we set up a shared folder. So we've got an IT system. So we would set up a secure place for you to send in the files so that we can access them. If that is something that is going to completely fox you, it suggests that you're not digitally enabled enough to facilitate this, and we would do a site visit.
Okay.
Thank you very much.
Just quickly raise a point that was put to me before this meeting. One or two people are clearly looking at where they get recommendations, or where they look at for the right software. And one thing that we have said before is that if people use, there is a list published by NHSX, which has a number of approved suppliers of care home or care use software. They don't have to use those, but it's a pretty good place to start.
So I think what I would say on that is CQC does not recommend any specific provider. What we would say is find the one that works for you. One of the biggest issues that we see, especially amongst smaller providers, is that you've been upsold and you've ended up with a system that is a system that's suitable for a dom care agency working with 300 people across 5 counties, when you're working with 10 people in one neighborhood. And you want a system that meets your needs, that you can edit, that you are confident with. If you are, and more importantly, that your care staff can access and use, and you can and you understand the functions for checking and auditing that. If you have to, if when we, I have to say my heart sinks if I do a go to site visit and I ask, oh, can you pull your electronic call records for me, and the provider has to phone the IT provider to pull that record, because that tells me that system is too complex for you to use and you're not getting the benefit of it, and quite often you're paying quite a lot of money for a system that is too difficult. So I would say always make sure that you can run your assurance systems and that it's a system that's right for your service, and you know, make sure you've got someone with you in the sales pitch, because they are, you know, they have very, very good sales teams, and I've seen providers who've ended up with systems that are far too complicated to meet their needs. So always be really careful. It's a significant investment for you guys. I really appreciate that, and it breaks my heart when I see that you've ended up with systems that are more complicated than you need. As simple as you need is usually a good measure for your systems.
I concur. Having worked with some systems and been part of a system, I think it's important to do your checks, try and have a trial period, but work for what works for you, because some are more suited to different settings, some more for dom care, some more for care homes or community care. So please do have a look, check. Peter did say, I think we'll probably end up sending the list of providers on the NHSX who are actually doing a great job and actually being diligent of what services have really been, they've sort of gone through themselves and had a sort of quality assurance check on them. So yeah, I think what Julia said is really important. And I think if anything, get to know your system as best as you can.
Just another point. Unfortunately, some local authorities dictate what system has to be put in place. As Julia said, these can be very expensive systems. They can be not fit for purpose. Arguing with local authorities is often not very constructive because they don't take any notice. But some are becoming quite enlightened, and they're happy to use whatever system you use, so long as it supplies the information, the data they need in the way that they need it. And we've always found that when the local authority has spoken to the provider of the software, there have been no issues. But I would point out that providers do have to input the software. It doesn't do the work for them.
Yes, templates do not provide care. It is always the content that we are interested in. Okay, and on that kind of note, I'll move on to the next bit about it's just a couple of slides about our new strategy. So we launched our strategy in April 2021. And we're trying to change how we regulate to improve services for everyone. So we're more relevant to the way care is actually delivered to people, and more flexible in our approach to manage risk and uncertainty. We want to be able to respond more quickly to risk as it's developing, and more proportionately, so we can keep those ratings up to date. Particularly with the pandemic, we know that our ratings have fallen behind where a lot of services are, and we're doing as much as we can to get out and re-rate, but we know that we're in a not brilliant pace in terms of the currency of some of our ratings. Our purpose and our role isn't changing, but how we achieve it needs to and will be changing. Our strategy set out an ambition to develop an approach to regulation that is driven by people's needs and experiences, the experiences of people and communities. We're focused on safety cultures and learning from collaboration across health and social care. We want to see how that collaboration can really accelerate improvement in services. We know we need to be better at how we use data and insight and use the best methods to gather all of our evidence. This is our strategic direction, and health and social care, it's not a stationary environment at all. We have to keep moving to keep pace with what you guys are doing. So this is a little slide which is about what our model now is in the top grey, and what we're thinking our future model will look like. So right now, and this is the current situation, is we have the 3 different frameworks. We've got registration, health and adult social care. We've got our 5 key questions. We've got some duplication across Chloe's. Not all of them fit. Some of them we're kind of shoehorning stuff in a little bit to get it to fit. And in the future, what we want to have is a single assessment framework that covers all sectors and services and all service types to help that will help simplify things for providers and for us. What we look at won't change, but how we do it is going to look and feel very different, and kind of inspections using remote technology is a step on that journey. So we're still going to be built on our 5 key questions, and that's what we're using to set out what our view of quality look like. Our current frameworks, and I know I don't need to tell you this, but at the moment, if you want to read all our guidance, we've got over 70 pages of ratings characteristics, and we want to simplify those because that's ridiculous. That's far more than we need. So we're moving to a single assessment framework that will be used for all service types at all levels, from the point of registration all the way through. That will make things easier for you and reduce some of that duplication that currently exists across our frameworks. So where we look at slightly different things at registration and at operations. As we've developed it, we've using the work done by Think Local Act Personal. I always get that the wrong way around. And about the Care Coalition on making it real. This sets out what good and outstanding person-centered care looks like for people using services, and is set out by people using services. Much of this assessment is going to be really familiar. We're not reinventing the wheel. But how we present it is probably going to look and feel really quite different, both for you and for us. So right now we've got 3 separate pillars of regulation and assessment. So we've got monitor, inspect and rate, and we inspect at set points in time based mainly on kind of previous rating. So we've got a fixed point in time. And we gather evidence in between, but we're moving away from that. What we want to move away from is from these separate steps and use information as we receive it. Collect and analyze information from you guys more often, but without being set fixed dates. We're going to receive this information in lots of different ways. So we'll have lots of information flow into our new technology systems, so that we've got clear kind of ways of presenting the information to inspectors. And I can tell you now that's already happening. We now have a single view. So if I was to go onto the page in our systems that is about your service, I would have a beautiful dashboard that tells me all the different things that have come in, and that we're going to keep building on that as we make sure that we're gathering better and more useful information about what's going on in services, and that information will help us make better decisions. We won't be doing fewer inspections. We are still going to be doing inspections, and you will still have specialist inspectors doing them. But we're going to be able to kind of make sure that the things that we're doing on site visits are the things that can only be done through site visits. So there's, like I say, the remote technology inspections are really kind of driving the path for this. The stuff that we don't need to do on site, we won't do on site, but it means that when we are on site, you won't find us in a office looking at folders. You'll find us out and about, making observations, talking to people, understanding the culture of the service. And we're going to be much more flexible in terms of how we prioritize inspections and complete them. At the moment, we make our judgments and ratings against characteristics, and we aggregate up to give an overall rating. What we're moving towards is to being more transparent and consistent in how we make our judgments. Our ratings are going to better reflect the care that people receive. We're developing ways of categorizing and scoring our evidence as part of our assessments. At the moment, our reports are long PDFs that are not particularly accessible to people who use services. They're time consuming for us to write and for the public to read, and realistically, I don't think the public read much more than the summaries. And so we're going to move away from that. We know they don't work for the public or providers. They're not accessible, and they're not what people want to know about services. They take up so much time, and they're not used in the way that they were hoped to be. So what we're going to do is we're going to have much more up-to-date view of quality. So we're going to make that much more streamlined. We're going to make them shorter, more tailored to the audiences that read them, and then they'll be able to support people to make better choices. So we're going to move from kind of huge long narratives to kind of short statements about what our findings were. And so this is a little bit more detail about the single assessment framework. So we're going to be moving, so we're still keeping our 5 key questions. They are absolutely the fundamentals of what we do. And we're still keeping our rating system because that's how we'll set out our views of quality and make judgments. Those are well understood by the public and providers. So we drew on the Think Local, Act Personal and Making It Real coalition, and we've developed the framework that will work across all services: adult social care, health, housing, dom care, nursing homes, care homes, supported living. And this will really set out what good and outstanding person-centered care looks like. We're going to use, so that sets out the, we will use the I statements as the starting point of our framework, the first important step towards regulating through the eyes of people who use services. So that will really focus everybody's kind of highest level is based on what people's experiences are. The 5 key questions are staying central, but we're going to introduce the quality statements pitched at the level of good, linked to the regulations that will help us make our judgments about the quality of care. These are going to replace our current key lines of inquiry. So we won't have key lines of inquiry, we will have quality statements, and these are going to be expressed as we statements. I'm going to be clear here that the we is you providers. So we as a provider will do this, not we as CQC. But this is about helping it make it clear to providers about what our expectations are of you and reducing the current duplication that we have across our CLOEs. Once we've got those we're going to use those statements across all sectors and service types at all levels. Then we're going to collect our evidence, and we're going to develop ways to categorise and score that evidence to bring in evidence categories, which will be weighted. The 6 evidence categories are people's experiences, feedback from staff and leaders, observations of care, feedback from partners, processes and outcomes of care. This will enable us to be clearer with the providers and public about how we use the information we have about the services to reach our judgments, and be clear about what evidence is required for us to make our judgments. Some of this is going to be data that's really familiar with you guys already, but by just bringing in the 6 categories, we're setting out how we're going to, it's just going to be really clear about what the ask is and what the expectation is. The single assessment framework will act as the golden thread from initial registration all the way through to the ongoing assessment. So we've got all that, and that's all underpinned by the best practice standards and guidance that we rely on to make our judgments. And those are the 2 slides that I can't share on your website yet because I'm still waiting for them to be signed off. So that's the bit that I just wanted to show you how it overlapped. I think I have now gone over my time with questions, but I hope that was useful to you.
Thank you very much for that, Julia. It's really insightful. I think, I'm not sure how long we've got left with you. Probably there were a few questions. I'm not sure if that's possible for you to answer before you leave. If anyone wants to ask a question, I know there was one question in the chat box. I know there are a few questions that were sent before, and some people sent me a few questions during this wonderful sort of presentation that you've had as well. So I think there was a question, I'm not sure if you can see in the chat, but from SHRH. We had a TMA call during the pandemic. I understand CQC need to see the care we're providing. If the TMA went well, isn't that unfair that our rating has not been changed for 2 to 3 years until CQC visit next?
So we are trying to get services. We know that we have not been able to re-rate for a really long time. Kate Taroney's most recent public statements were really clear. That is what we're trying to do. We are trying to get out and re-rate as much as we can. I can't speak to your specific circumstances, but we are out there, we are re-rating as much as we can. We have to go to risky services first. I'm sure you understand that, you know, actually we've got a duty to those people using services, that we've got to go there first, but we are catching up as quickly as we can to go out and re-rate. And we are looking for improvement and to re-rate. Kate has publicly committed to us to that. So I know that's very frustrating, but we are trying to get to services as quickly as we can. Obviously there were really good reasons why we couldn't get out, but we are now publicly committed to re-rating where we can and doing as many inspections as we can to improve those situations for people.
Okay, I think we've got a hand up. If you'd like to ask the question, please.
Hi, yes, good morning. This is actually a basic and very detailed question. Could you please, Julia, if you can please just clarify about I statement. Does CQC expect us to literally use I in our assessments and like put sentences in that way, or is just to make sure that we obviously take all information from the client? Because currently we always say that the client, the name obviously, wants to be supported in this way. So everything comes from the client. But the structure of the statement and the sentence, do you literally expect that?
This isn't about your care plans and risk assessments. This is about our assessment framework. So our assessment framework is going to set out at the very top the expectations that people can expect from care. So I can expect to receive whatever. And they haven't been written yet, otherwise I would give you examples, but we don't have them yet. That is not the same. So that's what CQC's position is going to be, is anyone receiving a service can expect to be able to say I blah 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 about the service they receive. What you're talking about is potentially person-centered care planning and the use of the first person in care plans and risk assessments. If it is true that it is what the person has said, use the person-centered, use the I voice. I'm always very cautious about using I if we can't be confident if it is the person's voice. So I you know, if you can demonstrate that you've involved the person and that it is what they want, and you can show that without using first person language, then that's fine. First person language, you have to be really careful that it is actually the person's voice. I used to work in services for people with complex needs and learning disabilities, and it was amazing how often the I changed with the key worker. So you saw people who, I love X activity, and then 6 months later I loved something that was quite a different activity, which was more of a reflection of the I, the support worker, than the I, the person who actually couldn't use speech to communicate. So there was a lot of kind of values going over that. So I think the I statements in this context, they're really strategic things about what I can expect from a care service. I will use my local hospital. I can expect X, Y, and Z. And I being used in first person language in care plans, they're slightly different topics there.
Thank you so much. That's exactly what I wanted to know. Thank you. Because there is always a mixture of feeling about, you know, among clients, a mixture of feeling about this I statement. Thank you.
And if someone says, I do not want my care plan to be written in the first person language, I think if you record that and say the person said they did not want first person language, no inspector is going to say, well, I insist that you write this in I, because that would be the antithesis of person-centered, which they had expressed.
Thank you so much.
You're welcome.
I think that's great. There was a comment about moving forward with things such as the PIR, the way you've spoken. Would that be redundant? Because the way you've spoken and explained it, it seems as almost that the information will always be readily available if we're using systems. So how does that work going forward?
So in terms of, so at the moment, are you talking about how we'll receive the kind of non-observation information?
Yeah, right, because I know it was PIR would usually be sent forward, people would be sweating and know that inspection was coming from that point. So
well, that actually changed 2 years ago. So now the PIR request used to be a kind of pre-inspect, it used to be a bit of a secret heads up.
Yes.
That has changed 2 years ago. It's now an annual request based on your first inspection date. So that is no longer tied to inspection. But what we're thinking is we haven't worked out the details of this. We are still consulting. There are workshops. Please sign up to CQC's participation platform so you can be involved in this. But it's more likely to be regular, smaller asks. We are actively keen to avoid duplication. So at the moment, for example, you guys do your capacity tracker stuff. We don't ask you for that information separately because we can access capacity tracker. So we're making sure that we're minimizing duplication, accessing pooled data where we can, and there'll be regular updates. So rather than it just being a once a year snapshot, it's actually something that you're able to continuously update and tell us about what's going on in the services. So our new provider platform is coming along.
Okay, sorry, just to raise a point about the tracker. Now I understand the tracker is a useful source of data and that social care is an area that is very short of data. Mm-hmm. However, the tracker was brought in because of the pandemic, and as the pandemic is possibly easing off, maybe the tracker is going, but what we're hearing is that the tracker is going to be kept in place because it's useful and may even be extended by way of more questions, but local authorities are expecting it to be done in effect for free.
I think that's not really a fair question to ask me to answer. I'm not. That's not CQC's data collection. We use the data in it.
Yeah.
It's not CQC's data collection.
Okay. Well, the other question, or one of the questions that was put to me, many providers are unhappy with the fee increases from local authorities, mm-hmm. and they are feeling that this is negatively affecting the care that they can offer. They can't meet the standards required, mm-hmm. and it's adversely affecting recruitment and retention. And several have told me that they plan to refer their local authority to their own safeguarding department, partly because of they have nowhere else to go to, but partly because if it goes to safeguarding, it is then, if you like, passed on to CQC. CQC doesn't regulate local authorities, that's a given, but CQC is going to take an overview. Exactly, is going to take an overview.
So right now our hands are tied because the law hasn't changed yet. But we are also, again, please sign up to our participation platform. If you do nothing else as a result of today's call, sign up to CQC's participation platform, where I've signed up to it and I work for CQC because it means I get an idea of what's out for consultation as I go. Obviously it still has, the law hasn't been changed yet, but when it does, we want to hit the ground running. So we're doing a lot of consultation and early work on what the regulation of social services will look like for us. And we are involving providers in that. And if it, what isn't in scope is kind of up for grabs still. So I would very much say get involved with that. We have currently no control over provider budgets, and I really appreciate it's such a difficult position for providers, but if you're not able to safely meet needs, you've legally taken on that package of care, and under our regulations, if we come and inspect and we see that people's needs are not met and we can't see that you've escalated that, we need to be able to see that you are escalating that package is unsafe. That's what we need to be able to see, because if we can't see that you've escalated it, it's going to look like you've not met that person's needs.
Yeah, and I think that's a very good point. And one of the people that called me, they have had clients for several years who have not had a reassessment, and they have asked for the reassessment on an annual basis, but it has not been done. And their feeling is, rightly or wrongly, that the local authority has ignored these because there would be a potential fee increase. So in effect, the fees haven't been raised for some years. But having gone back again to the local authority has now said we have no trace of being asked for reassessment. But what I've said, always say to people is make sure as a provider that you keep a copy of anything that you sent and ask for a read receipt or a received receipt.
I would very much support that position, Peter. I think, if you're supporting someone and their package does not meet their needs, we would need to see that you have, and if you can't show us that you've escalated that, if you can't show us that evidence, then it looks like you have it sits with you. You need to show us that you have escalated it.
Exactly.
There's a couple of little points in the chat that I can see around providers not being able to get packages due to not being rated. So we can only inspect services that are delivering regulated activity. If you are not delivering regulated activity, we can't inspect you. There is nothing to inspect. If you need to, I understand a lot of local authorities won't commission with unrated providers, but you can still seek packages privately. That is within your gift. In terms of if you're new to the market, I would suggest that the understanding of local authority commissioning arrangements should be part of your due diligence before you set up your business. We cannot inspect you until you're delivering. And if you were not aware that your local authority wouldn't commission with you, that is, I'm afraid, your business planning failure, not my inspection failure.
Another question, sorry, before you go into that, we know that targeted inspections are taking place. With targeted inspections, apart from the actual area you're targeting, is it a chance as well for some of the providers to actually showcase what they're doing and increase their rating? Or is it just the targeted area that you're looking at?
So when we do a targeted inspection, it's usually just to follow up on a concern, and it will depend very much on what your existing rating is and whether we think that that is a fair reflection. So if you are currently rated good and we go in to do a targeted inspection because we've received information of concern, if we have concern, if we find that that concern is founded, and therefore we have concerns about the integrity of the good, we will open up that inspection to re-rate, because we, you know, particularly if we find evidence of a breach, you can't be good with a breach, we have to expand that. If we go in to do a targeted inspection to follow up on previous concerns, so to see if we can close down a warning notice, if that was the only concern we had, and we find that it has been resolved, again, we can expand that inspection to, as you know, whatever the minimum unit is. We have to do the whole key question on well led, and if that so that we can amend the ratings. Okay, so if we think that the targeted inspection either finds concerns or finds improvement, our methodology is then that we would then expand the inspection to be able to re-rate. But if we go in and it's a good service and we go in, find the concerns not there, there's no need for us to expand that. We're confident that good is still got its integrity. If we go in and it's a requires improvement service, we target, we think that concern is still founded, or we see enough while we're there that we're like, you know what, it is still requires improvement, it's not quite got to good yet. If we re-rate you and reset that clock at RI, you will be waiting longer. So we might go, you know what, we think the RI is still right, those concerns were there, we're not going to expand and re-rate. So we would re-rate if we thought from what we'd seen we'd be able to improve the rating.
I think there's two more questions, I think, in the chat. So I think if you... So
there was the question about the slides, which we've covered previously. So the PIR is part of the inspection because it informs our inspection activity, it informs our knowledge and kind of picture of what's going on in the service. At the moment, the PIR is annually, that might change. In terms of frequency of inspection, please get involved in our participation platform. We are working that out. At the moment, we have no fixed time show.
So a very quick question someone asked. Someone that I've spoken to said they were told that they did not have to fill out the PIR, is through choice as opposed before where it was essential. So can you clarify that?
We request it under the, you know, if a failure to complete it is an indication of risk, and we can use section 64 to require it. So a failure to complete a PIR would be a big indicator of risk in your service, because it would suggest that you had not understood the requirements of being registered with us.
One other point, I was asked about the CQC widget, and this was, excuse me, a couple of weeks ago.
Widget.
Sorry?
Is that the website widget?
That's the website widget. And I actually checked this out with CQC Towers and was told that it is a legal requirement. And we see a huge number of websites that don't have if like the proper link or any link to CQC at all. And I've even come across them when they've had an outdated link, when, surprise, surprise, they had a good report and now have a RI report.
Yes, we have noticed that. So it is a requirement to display your ratings. I hadn't realised it had to be the widget. That might be an.
It doesn't have to be. Sorry, it doesn't have to be the widget.
It doesn't have to be the widget, but it has to be clearly displayed on your landing page of your website. Now, obviously, if you're a huge corporate provider and you've got 500 locations, it's normally on the locations website, but it needs to be prominent. And it needs to not be hidden behind links and links and links. And it needs to not just be a link to CQC report. It needs to say what your overall rating is. It is an offence to not display your rating, and we can issue a fixed penalty notice. Very topical.
Yeah. More than 50 quid.
Which means I am aware of exactly what legal thresholds you have to have reached for an FPN to have been, because failure to pay an FPN is prosecutable. So but yes, display your ratings, and if they're not displayed, that is something that we can follow up on. If you've got a website, you need to have it on there, and you need to have it on there really clearly. South Care Homes Group has asked about interviewing new managers. I know that there is a delay, but I didn't think it was horrific at the moment. Has their application definitely been accepted?
I think we're not sure, we're waiting for that. I mean, how long do you know, I mean, you may not hold the exact time frames of how long it takes for a manager at the moment.
No, I don't know how long it's taking at the moment. I know our targets haven't changed. I know that overtime is available to do registered manager applications. So we are trying to, I think there is a certain amount of backlog. I was not aware it was worse than normal, if you see what I mean. Okay, DBS was sent a few months ago. If you've got a ENQ number, do you want to pop that over to me and I can look and see what's happened with that? Don't obviously put it in the chat here, but my email, please don't all use my email address, unrestricted.
Or send it to me.
If you send it to Peter.
Send to Peter.
I just had a moment, I was like, oh god, there's like 100 people on this call, that's unwise. But if we send that to Peter, and then so the ENQ number that you got for that application, send it to Peter, I'll have a quick nose.
Yeah, I will. And
I can't agitate to get them done, but I can at least tell you what stage they're at.
And can I just say that having seen quite a lot of CQC application paperwork over the years, we're not here as a free service to fill it in for you. And when you fill it in, please read the instructions and actually do fill the boxes in, because it will come back if you don't. And some of it may not be very clear, but if it isn't very clear, then do ask the question, rather than just phone them up and ask the question, rather than just bin it off and it'll end up coming back to you.
And also, just I know you've got another presentation coming, so I will dip out so that you can have that, and then you can talk about me while I'm not in the room, because I know you want to do that really. I will also say our new, I know that CQC has been promising that provider platform will get better for years, and it's been like false promises, and it's been you told us the forms will get better, and all you've done is add an extra box. I promise. Ooh, that's not me who's changed that screen. It is changing. It will get better. We're going to make it so on the forms you can't complete it if you've got it wrong. So that thing where you can miss a form at the beginning, and we're going to all of that kind of validation is going to be inbuilt into the new forms. Early testing is looking really strong. So hopefully, again, go on our participation platform, get yourselves involved, because I know we've been promising it for years and it feels like a big lie, but it is so much closer to being actually good. So yeah, please
thank you very much for that. There was a question, I'm not going to ask you to answer it, where someone said, what is give us an example of outstanding, or what does it need to become outstanding?
Look at the criteria. So I think I'm going to defer to your outstanding provider who's presenting, but I'm going to say the one thing I will say is, by all means, read other reports of outstanding providers, but duplicating what someone else has done is not going to get you to outstanding, because it was outstanding for them because it met the needs of people who received their service. you are supporting a different group of people, so you will need to do something that is different. So there was a spell when care homes had lots of pets visiting. And because one care home that had been referred to as an example of outstanding evidence because they'd been able to demonstrate the impact on people and how it had really improved those people's lives, that was evidence for outstanding. We then had a multitude of care homes saying, we have pets as therapy, that means we're outstanding. But where they weren't able to demonstrate the impact on people and why it met the people they supported's needs, it's not an evidence of outstanding. It's got to be the right support to make a difference to the people you support, not just replicating what someone else did to meet the needs of the people they support.
Julia, many, many thanks. That was very, very useful. You are very welcome to stay.
I'm afraid I won't. I will get on, but it's been lovely speaking to you, and thank you guys. And yeah, any follow up, go via Peter, and he'll be in touch.
Okay, and we'll get the slides when we can, and they will be
as soon as I've had them signed off.
Fantastic.
Thank you very much, Julia.
Thank
you. We will be in contact.
Cheers.
Great. Now then, I'm not quite sure why we've got Merton's screen, but maybe I'll try and pull up Aghileh's presentation. Yes. All right, so that worked.
Okay.
Okay, brilliant. And Aghileh, are you fit to go? Good to go?
Yes, I am.
Okay. Well, if you tell them where you're coming from and you're off. Do you want me to move the slides or do you want to move them yourself?
If you do move them, I would appreciate it.
No problem.
Thank you very much. Okay, so good morning, everyone. I'm Aghileh Hatami. I'm an Iranian qualified nurse and have been working in both the clinical and community setting since 1997. And currently, I'm the registered manager of Care Concern. Care Concern was founded in 1993, way before the regulations were introduced. So clearly, the company had to keep moving and improving and making changes. But ultimately, the core of the service has always been around the clients and how to meet their care needs efficiently, promptly, and competently. I'm going to obviously explain a bit more about those three things that I emphasized with my tone, but I really want to say about promptly now that it really needs to be prompt. When you face a situation, prioritize and deal with it promptly, and that's the key, one of the keys. Our 5 values, if you, Peter, please go to slide 3, then it shows our main values. That is being compassion is number 3. If you go back, please. Our values is number 3. So I am going to obviously speak about it until Peter gets the values on this slide on, but it's okay. I can tell you about our values. Being, having compassion, having empathy, and having understanding about clients' needs, and respecting individuality. In our dementia training, for example, we say that everybody is different, and we always emphasize on the importance of knowing that everybody is different, and telling our staff that not just knowing about dementia and what is dementia doesn't mean that they can get this information, take this information and implement in every single client's house. It has to be different. So individuality is really important for us. We are dependable. Obviously, we try to have consistency and treat our clients with integrity. we do talk about expert, and obviously knowing what you are going to do and expecting people to do what they are actually being trained for. So training is the main important thing in my sector, because I'm one of the trainers in our company. I'm the lead for dementia, end of life, and medication. We always look for right personality. Yes, of course, it's good to have someone who has done care certificates, but it's not the things that we really, emphasize on. Our focus is on the right personality. So we look at the person to see why this person wants to work as a care worker, and then we train that person because we are really confident about our training. And the other value that we have is respect. We really respect equality and diversity. We celebrate diversity. Our office team is quite diverse. It's really useful when you have, phone calls with clients, and they are asking about the nationality of our staff, their level of English, and all those things. So it's really useful that I always say that yes, we can speak English. We all may have accents, but we understand what you're saying. And obviously, when they see you as a representative of the company, they have that trust. They know that your staff goes there, and sometimes, because there's always this misconception about having an accent, they immediately think that, oh, this person doesn't understand what I'm saying, but that's not the case. And actually, there is a famous saying that it says that when somebody has an accent, it means that that person knows another language. So that's a plus. So we celebrate diversity. And about our company, the director and the owner of the company is Claire Joel. She obviously founded the company in 1993. She is the responsible individual, and she's involved in very important decision making. She is a massive support for me. So when it comes to making important decisions, I always get in touch with my team. And I'm going to just speak about some bullet points about how we managed to maintain our outstanding rating. So we were actually inspected in 2019, and we were outstanding. But in 2021, we were informed that we were randomly chosen by CQC. And it was just to make sure that the companies, the providers who are outstanding are really outstanding. And it was, in fact, it wasn't a focused one. It was a full inspection in person. And I just made some points here, as you can see on this slide, our key to success, that these are the main things that I would really, as one of your peers, advise you to focus on. Communication, it has been always important to me. And, just not wasting time reading, keeping up to date, and sharing that information with your staff. For example, during the pandemic, one of the things that we were really like a pioneer was because we were constantly attending webinars, especially from Skills for Care. And this Registered Managers Network meeting has been amazing because I've got a lot of information and tips about what to do about different, areas. And also we have had, over time, we have had so many, occasions that we had speakers from CQC, speakers from Citation, and Skills for Care itself. And it's been really, really valuable. So our carers were saying that they didn't need to watch TV to know what's the guideline, what's the information about COVID-19 and all those things, because we were giving the precise and really prompt information to them. So they were feeling sort of equipped to go out and work in the field. Time management and prioritizing. I understand that we as registered managers have numerous responsibilities in every companies that we work, but it is our skill to prioritize and to understand which one is first to be dealt with, and really, work efficiently. The next thing that I already pointed out is the staffing and training. It's really important. We know that obviously care certificate is a basic fundamental training for care workers in our sector, but we always put our own stamps on their training when they come and they join our company. So no matter they have done the training, we still do train them for some areas, plus definitely for dementia medication and then end of life and moving and handling. We have created workshops ourselves. When I say ourselves, is that we have done train the trainer, and then what I have done after that is not that I just delivered that. I made PowerPoints myself, and I have been delivering those training, as well as my colleague who's the lead for moving and handling. She has a workshop. She does, practical training, and it's amazing. When she does the training, you will remember her training for the next 10 years. The other thing that I would like to say that is really important and has been really, really useful for me has been the group discussion and getting help from my office team and my management team. As I mentioned before, Claire Jurel, who's the director, and our operations manager, Laura Jurel, and our care manager, Bernadette Kendall, and the care coordinator that is actively working with me, Faith Aghileh. I have been always asking their idea and their opinion when there is an important decision to make. I remember back in 2020 and 2021, we had some evening meetings even. When something happened that was really critical and important to make decision and know what we are going to do, we just had the meeting. We just came together and we discussed the situation and we decided what we are going to do next. And that flexibility from my team, management team, has been amazing. Staff support, peer support, and phone calls. It's really important to support your staff, because if you do give that support to your staff, they are going to go out there and give the best thing, the best care they can to your clients. And the value of making phone calls and welfare phone calls to our staff have been really noticeable, because we do call them to see how they are, just sort of like informal calls, just to see, how they are feeling, and showing them that you are a human being, you understand their situation, have empathy with them, and actually genuinely you show them that you are with them. And I have gone out, even though it was, for example, for a time, going out was restricted. I was following the guideline, and I was making sure that we are seen in the field by our staff, for them to know that we are still out there with them, visiting clients if needed, or even I dropped a sandwich for one of my staff at work when she actually did me a big favor, and she accepted to go to the next client, and she didn't have a break enough time to go and do shopping. So she used her travel time to get to the next client. I went out and I got her, something to eat. And, it's not, I'm just giving you examples. I haven't done, massive things for her, but I'm just saying that they are doing their best for us, and our responsibility is to support them and to make sure that they feel supported and valued. The next point is digital system innovation and virtual meeting. So once we couldn't go into the office and do the training, we immediately started to change and make our training deliverable virtually. So we had meetings, we had even welfare calls and Teams calls with our staff, and we even did some of our supervisions virtually. There were a lot of innovation going on in our company in terms of even different aspects of our PPE and all those things that we needed to consider and make sure that we are in the right place. And we were so lucky that just before the lockdown, we had all the documents on shared folder, on shared documents. So everybody could work from home because we could access everything, all the documents about all the information about the clients, about the staff. We could do all the observations, and we had this digital system that we could read care notes. So, and also review mar charts, and everything was digital, and it was just so lucky. And I really encourage those who are on the process of becoming digital to make sure that you are buying the right software, because if you buy the wrong one, then you have to spend plenty of time going back and making sure that you got the right one. And this is not a personal experience. We were fortunate to be using the right software, but I did attend Care Show last year, and I got a lot of information there. And that's another thing that I would encourage you to make sure that it is also can also be part of your CPD, to make sure that you attend this kind of care show, Alzheimer's show, and like home care association conferences. If you're a member, definitely these webinars that are organized by Skills for Care and Registered Managers Networking. This one has been amazing for me. And the next one, keeping up to date, I have already mentioned a lot about how important it is to allocate time and read what you need to read and to keep up with the information, because obviously we all have experienced how quickly things were changing, and the guidelines were constantly changing, and we should be just constantly reading and understanding, okay, what now, what kind of PPE now, and how we're going to do the test and all those things. So it's really important. Again, it goes with time management. You might have plenty of things to do, but make sure that you read those emails. Just don't flag them up and leave them for later. Make sure that you allocate a time to read them. Communicating with our CQC inspector has been always very useful. One of the things that the opportunities that I had was ESF, when they were actually gaining information through that through ESF. So I had the chance of giving her information about what we are doing, where we are now, and then getting a feedback from her that, okay, so we are managing. And also, obviously, if we had any question, we were communicating with her, and she has been always, promptly replying to us, and obviously in line with her job, requirement, she has been supporting us. Working efficiently with other professionals, I have had, a lot of active communication with GPs, OTs, district nurses, and our management team have been calling different, professionals regarding our clients. Obviously, we knew that throughout the lockdown, professionals weren't really visiting as often as before. For example, I had an occasion that the OT said that I can't go and visit this client, and then obviously she needed to measure the chair and order the recliner chair. So that was done so very efficiently. And also we facilitated some video calls with GPs, and we sent pictures prior to the GP's meetings about one of our clients' end of life. So they had all those pictures in time to make decision what is needed for this individual. We have been working with other professionals really very widely and very efficiently, and that has helped us to provide the right care to our clients, because sometimes, for example, the medication needed reviewing, giving GPs information about the side effects. Okay, so a medication has been prescribed, So we are really effectively communicating that information back to the GPs about, what is needed and what is happening for the client, so they have information from us, because we have to all appreciate the fact that sometimes clients, our carers are the only people who visit our clients. So this, just by knowing that, and obviously we all know that, but just by reminding that and knowing that there might be some safeguarding issues, there might be some issues that the other professionals are totally unaware. It is our responsibility to share that information, obviously in line with confidentiality and GDPR. The next one is reflecting and learning from mistakes. When I call my staff when they have made a mistake, I always tell them and reassure them that they need and they can be transparent with me and just tell me the exact information, and that's how I can help them, because we all make mistakes, and you need to tell them that, and you need just to make sure that they feel supported. So the mistake has happened. CQC doesn't actually, sometimes I heard that CQC, if they go to a company and see that there is no medication error, they actually are more concerned. They are thinking, actually, no, there can't be no medication error. It's the fact that you are actually not gathering the information about medication errors. So I really advise you to make sure that you have this kind of really supportive environment for your staff, to tell you that they haven't made a mistake, so that mistake has been addressed and dealt with properly. And that is exactly what CQC wants you to do. And they want to see that, okay, this is the error, what we did, this is the outcome, and what we learned. And then implement your learning in your system. So, and make changes, because obviously something has happened, why it happened, and the outcome. Julia actually mentioned something in her presentation, and I just want to repeat that. The main thing that CQC wants to see, and for example, when she was saying that don't copy other companies, is to see the impact, the outcome, and it's your job to be able to evidence it and provide evidence, and have that information that this is the condition, this is the situation, what we did, and what is the impact, what is the outcome, and then see in terms of all those 5 questions: safe, effective, caring, responsive, well-led, which one actually is related to what you are right now doing. So evidence, and keep that evidence for your future inspection. Don't wait for your inspection. Don't wait to be informed that you're going to be inspected. Don't wait to be asked for your PIR. Have this information and this evidence ongoing, and just have somewhere to record this evidence, and just develop and just improve and add on for when you need. Because once, for example, some 2 years, or if you're lucky, after 2.5 years or 3 years, you're having your inspection, then you may not remember everything. So it's good to have that evidence. I said if you're lucky, but to be honest, having the inspection in 2021, even though it wasn't even after 2.5 years, it was really lucky. I feel actually lucky to have that inspection. I always had a positive attitude about inspection, because that is for me to know where I am and how I can improve. So I encourage that positive attitude, and I encourage you to communicate with your CQC inspector. I encourage you to attend these meetings and make sure that you know the most updated information. And the next slide is just about what we have learned. The first thing we learned was that there was never an end to our learning. We had to continue learning, especially while dealing with the situation that was totally unpredictable. Being able to speak to staff whenever they need support, or when they have a concern, is really important, because that also builds a very strong relationship between you and your staff. Don't avoid difficult conversations. This conversation had to be done to clarify and avoid assumptions. We've learned that being transparent with the staff and clients, obviously considering GDPR guidelines, is really valuable. It is to show them that you're not just a manager with some rigid instructions. And continuously reviewing our policies and procedures, because obviously throughout the lockdown, when we should be having some video calls, we should be sending information to other professionals. It was really important and very difficult. But also we needed to review our, GDPR, our internet communication policy, all those things that were relevant, to make sure that our staff know how to share those information, what to do with that picture or that video and all those things. So we did continuously reviewed our policies and procedures. And networking and attending Skills for Care, Home Care Association, CQC, and other relevant webinars that I have already mentioned. And we have learned that we too deserve a pat on the back and celebrate our achievements. So I have finished. I'm ready to take any question if there is any question. Thank you for your time.
Many thanks
for that, Aghileh. I think that's really fantastic. I love the element of using your skills, the people around you, the inclusion, diversity, and also as well using events like this to represent CPD points and training, put it down in your training matrix for yourself and your staff. I would concur. The healthcare show is a great show to go to. I am having a session actually on inclusion diversity. Well, I'll be speaking there, so do come down and join. But we'll update you from there going forward. But thank you very much from your point of view. I'm not sure if there are any questions directly. If not, because we are running short of time, to also we can do have a WhatsApp group where you can actually send questions in there. So I think there's a question in there. What do you speak to your CQC inspector about? And I don't know if it's about the weather outside. So that might be a question that every inspector is different, I would say, and it's a relationship you build, but not every inspector is always forthcoming. But it's good to work a relationship with your inspector, because it's really helpful to have an understanding of what they're looking for and potentially what they can help and advise you with as well.
Thank you. Yes, that's exactly what we have been doing.
Okay, I think if there are any questions, if any other points, if not, I'll just flick through some slides that I've got from Skills for Care here. Okay, just let me pull these up. Actually, just let me go out and find these slides.
I know time is probably running short for most people. There are a few bits before we go, apart from Skills for Care, that we will be sharing as well, if those are still in the room presently.
Okay, just got a problem here because it's telling me that the doesn't seem to like the, hang on, we've done that. Unfortunately, Skills for Care couldn't be with us today, but they have sent us some very, very useful information, partly about what is on their website, which I'm trying to pull up, and also about the advent of the LPS taking over from DOLS. And that's why I'm keen to get this, hopefully good stuff. Can you hopefully see that?
We can, Peter.
Okay, but it's not going into, okay. They've got a very good range of information and guidance on their website. Now, what I would ask people to do is to actually use the websites and the information available. Not just Skills for Care, you've got NICE, you've got Sky, and try and build relationships with other managers you know, as Aghileh had just said to you. On this slide, there's actually a module that you have to buy from Skills for Care. It costs you a tenner, but you can actually claim £50 back for that. And it's good quality training, and it's worth signing up for Workforce Development Fund as a contribution to your training budget. Okay, it involves NMDS or whatever they're now calling it, but one of the facets missing from social care is actually data, and at some point in the near future, social care providers are going to be forced to provide the data. So frankly, you may as well get on with it. There's also a lot of other information. We will share these slides to you. They have got the links on them. The checklists are useful. They're actually good. And keep checking back with Skills for Care, because they are bringing stuff out month in, month out, all of which, or most of which, to be fair, is free. If it has a cost, usually that cost can be claimed back through the Workforce Development Fund. Okay, liberty protection safeguards. We all know that the LPS has been in the background as a replacement for a considerable time. It hasn't been introduced. It is now going to be introduced, and it will be coming in quite shortly. We don't have a definite date. And what I would say to you is avoid some of the training that's being offered by companies telling you they have all the answers and they know exactly what to do, because they probably don't. And if we look at the next slide, there's two very interesting points on the bottom here in green. It will apply to people in their own homes for the first time. Very few dom care providers had to deal with dolls. And it also covers people over 16, which could technically be counted as adults or children, whereas dolls only applies to the over 18s. There's been a consultation. There still is a consultation, which finishes on the 7th of July. Where consultations come out through Skills for Care or the CQC platform, do please contribute. We frequently go to meetings with Skills for Care or CQC, and they say, we put this out to consultation, we've had no response. They can't make it up. They need your help as providers. So please do, support them by helping them. There will be some information coming out. There is already a video and some information on the Sky website. Again, it's free, and there's a link on the bottom of the slide, and also to the DH update as well. And you'll need to actually add that to your training to show to CQC and to local authority quality monitoring teams that you have done this and that your staff are competent with it. Okay, that's it for that. That slide set will also be on the website. Any questions for Dudley or myself? And my apologies for taking up a bit more time than normal. Oh, great stuff. You're still on mute, Dudley.
Yeah, sorry about that. I think I'm. Can you hear me now? Can you hear me now, everyone?
I can.
Very quickly, I've been part of a team who have called a group known as Institute Health and Social Care Management. It's about the public image for health and social care. I've produced a document called the People Plan, which is we've gone up to the House of Lords, and it's really about changing the image of health and social care. It's something that we all can get involved with, and it's really made by ourselves for us all to share. I'll post the information in the group for anyone who wants to actually go on a Zoom to actually listen to it. And it should be interesting. I'm one of the speakers on there, but it's something that's really trying to give the government direction, the likes of CQC and really showcase what we can do. So please do feel free to join that at any time. That's one of the things I would concur. So I've sent information in the box, and Peter will share it, and so will I, in regards to that. So I will stop sharing my screen. And there was one other thing that I wanted to ask finally, is that I've been part of something known as a cook-off event for health and social care staff. And it's a battle for jollof rice that's taking place. It's for those attending the pictures of their jollof rice and participate, especially more in South London. And then it's going to involve a final where people will be judged. It's something fun for the staff, where everyone can be involved in. So I will post that there for anyone just to participate in. And I guess we take forward from there. Thank you very much for everyone listening to this show today, or presentations. Have been really great information from CQC, from the how to be an outstanding manager, and all the bits of legislation that takes place. I've got a hand up here by Olufunke, and she's on mute. So.
Sorry about that. Morning. Thank you for all the information. I just wanted to ask a quick question. Dudley, the link you sent to register, it's not working.
Which one? For the people plan?
People plan, yeah. The first link.
I will send it. I'm surprised it's not working. The first one I'll register, it's not working, is it not?
Register to join free.
Okay, well, I will send it again. Thanks for letting me know.
No problem, thank you.
I've just put 2 quick points. Warwick University are doing a very useful piece of research, and I've just put the details in the chat. If anyone can contact them, can be part of that, please do. If anybody wants to talk to me about Vivaldi, which is the infection control in care homes, again, please contact me. That's a very useful piece of research. And we've slightly changed. We've updated the LCaS forum website, and the name has changed very slightly. And some people are not picking that up. We have circulated it. It's in the chat now, and I will send it round again. It's all the information is going on there. You may need to refresh your screen, I guess, to get rid of the old WordPress site. But the new one is a lot more easy to use, hopefully. And prettier.
Peter's gone digital.
Sorry?
We're going digital.
Exactly. Even at my age. We have another meeting on the 27th, same time, 10 till 11:30. And that is going back to visas and importing staff, mainly because with Fragamen and Skills for Care, mainly because we were asked to get them back. They're coming back. They've recently supplied a whole pile of Q&A, but they will be coming back on the 27th. So if you have any points about visa applications, etc., they will be there to answer them for you. Okay, so many thanks to you all, and have a good couple of weeks, and we look forward to seeing you on the 27th.
I've just sent the link for the event that I'll be taking part in on the 28th. So it's a virtual event that you can come and register on the 28th of April and get to hear a lot of the things that have been done. In the link I've sent is the actual people plan, but I'm going to be talking about the public image of health and social care. So please do join in.
Okay.
And if you can't download stuff, or if you've got a problem, if you contact either Dudley or myself, we will endeavour to resolve that issue for you. Okay. Many thanks.
Thank you, everyone.
Thank you.
Bye. Bye.
Bye. Thank you.